Welcome everyone to our chat session for this week, which is on Coccyx pain. I've got Mel Smith, delighted to have Mel with me. Mel is an awesome clinical expert in the area of Coccyx pain. So hopefully you'll really enjoy the session and it will assist you if you're suffering with this at all. Mel works out of our practice at Taylor's Lakes and also at Yarraville, but she'll be going across to Taylor's Lakes next year exclusively. So if you know anyone who suffers with Coccyx pain, please don't hesitate to send them to Mel because she is brilliant. So Mel, do you want to start by giving us a rundown of what are the main reasons why or how someone comes to you with Coccyx pain, how it's caused in your experience clinically?
Right, okay. I think we'd split this into a few common causes. One of them would be obstetric. So if there's been a vaginal delivery, and it can be a bit dependent on what position they deliver in. Sometimes there can be a bit of a coccyx stretch with the delivery. And that's probably one category that we'd see. Another pretty common category is just falling. So falling, or if there's been a hard bump on a bicycle seat or a motorbike ride or something like that. So some sort of trauma. And one thing that can happen is sometimes the trauma at the time can resolve and they can get less pain, but then they represent later on with a new onset of pain for some reason. Another category is just insidious. So insidious meaning there's no particular one mechanism that caused it, but it's typically something like an increased amount of sitting. So it's the same as if you suddenly did heaps more walking and your feet got sorer because you did heaps more walking. Heaps more sitting makes your bum hurt more, right?
Absolutely.
So sometimes we get stories like, I was fine until I went overseas on a trip on a bus, and it was a bumpy bus trip through regional wherever, and the bumping and the time sitting, or I've changed. Recently there's been a lot of I'm working from home, and so sitting on a different seat, different ergonomics, different chair, and they're going, now I'm getting pain, and I didn't because at the office I had to get up to move around a lot more. So that's probably the other one. Those are the three main categories I think we'd see.
Yep. And what about like the acute stuff? You've just brought to me, I think we probably see much more of the chronic. So by the time they've come to us, they've been to a lot of people. The acute stuff, do you have a different management plan for that?
Certainly, if you think there's been a trauma, yeah, because you've got to eliminate whether there's been a fracture or some sort of injury that needs proper healing time. So if there's been a fall and you're suspicious that there's been a bony injury, you'd have to go and do imaging, x-rays. Typically ultrasound wouldn't be that useful for it, but yeah, x-rays just to see if there's any proper bony damage.
I find it's hard in these ones because you kind of go, okay, so there's a fracture or there's a dislocation. What are we going to do about it?
Yeah.
Because it's the evidence and or the success rate on reduction of these through a manipulation is still a bit,
and often they don't need a reduction. It'd be pretty rare that they need some sort of reduction. It's more your expectations of time frame to recovery and what you might do for management. So if there is a fracture line, you'd probably be a bit more conservative with putting pressure and things around the area. Whereas if you've eliminated that and you go, okay, well, we're thinking that it's more just muscular tightness, there's some stiffness and things involved, you'd be more likely to get into it and treat the site directly.
Perfect.
And it's, how long you expect the site to be tender for. So if you put pressure on any fracture line, it's going to hurt for, if you think about how long people hurt when they've had a kneecap fracture and they can't kneel on it for a really long time, months. So if you sit on that fracture line, it's potentially months of being, you'd expect it to be tender.
All right, for those of you listening, please don't forget to post your questions as you go along if you've got any particular questions for Mel. So Mel, if I'll get the slideshow up just so that if you want to use any of the images to talk about. So let's probably assume the person's not acutely sore, but they've got this achy coccyx that they've had for quite a while, probably 6 months plus, sometimes years. What do you do with these patients? And I'll pop the share screen up now so we can kind of go through and you just tell me what images you might like to kind of help discuss this.
Trying to figure out where it's coming from? Do you mean where we go for management or where do we go when we're trying to...
Yeah, what would you do in an assessment?
Right, so The thing about a coccyx is sometimes it's not pain coming from the actual coccyx. Have you got a picture of where the actual coccyx is in the pelvis?
Yep. Yep. Let me get this started. Okay.
So go, I think, yeah.
So
That down the bottom there, that tail.
let me get the bony one.
So if you think about that big triangular shaped part, that's the sacrum. And then the part down the bottom, the little tail, that's the coccyx, right? So what you call coccyx pain, or what someone comes in describing as coccyx pain, isn't necessarily coming from the actual coccyx. So part of what we do in assessment is try and problem solve whether their pain is actually coccyx or whether it's sort of pretending to be. One area you can get pain that's pretending to be coccyx pain is from your lumbar spine. So lumbar spine is just your lower back. And because of where the nerves are running and because of where the joints can refer pain, sometimes it's actually coming from lumbar. So there's some testing we can do to try and figure that out. The really common site we see it referring from is the actual pelvis. So I don't know, Alex, if you run your marker up and down that picture where the other people can see the marker.
Yep. Yep.
So
Where do you want me to run?
The SIJ, or the sacroiliac joint in the pelvis, that's one big joint on either side, and that can be a site that can refer to the coccyx area because of where the nerves run and where the ligaments refer to, where the joint refers to. So there's a lot of testing we can do externally to try and figure out if that's where it's coming from. Movement testing, palpation testing, which is pushing on the joint. And there's a few scenarios where referral from that joint is more likely. I think pregnancy for us is one of them because of increased mobility in the joints. So all the postural changes you go through with pregnancy, all of the hormonal changes you go through change how much play there is in the joints, how much mobility there is in the pelvic joints. So you end up with the joint sometimes becoming grumpy, which can appear like coccyx pain, or you can get guarding of the muscles around that area to compensate for that increased mobility, and that muscle tension can then cause some coccyx pain. I think there's a different picture of where the muscles are attaching on.
Mm-hmm.
So part of what we do in assessment is we try and come back to what do we think the actual mechanism is. Is it the lower back? Is it the pelvis? Is it where the muscles are attaching? You can see the big glutes, the big bum muscles attached right onto the coccyx. And one of the deeper back of the pelvic floor muscles also attaches onto the coccyx directly. And then the rest of the pelvic floor, if we've got another picture of that. So if you're trying to orientate on the picture, yes, that triangular bit there that Alex is indicating, that's the coccyx there. So you can see if you move upwards in the picture, that's your pelvic floor. That first hole is anus. And because this is a female model, the hole above that's vaginal opening. So we're looking at kind of upside down, if you like. You can see all those muscles of the pelvic floor attach onto the coccyx as well. So sometimes what we find is actually what we thought was coccyx pain is muscles of the pelvic floor referring to the coccyx. So part of our assessment can be external, looking at all those factors. And if necessary, we can walk someone through the benefits of an internal examination, trying to figure out if an internal exam is going to tell us where the pain is coming from. And then that can lead into treatment internally for where it's necessary, or it leads us into an external treatment for all those other parts we talked about. Does that cover your question?
It certainly does. So you'll look predominantly muscle, so as everything attaching to the pelvis, so you'll release the muscle tension and guide your patient through that. Then you'll look at joint, all the possible joints that go through or can contribute to coccyx pain.
It is
and
the
then
actual coccyx, yes. And then if it is the actual coccyx that's hurting, we try and figure out whether it's the muscles or whether it's the joints of the coccyx, because some people have the coccyx as one fixed bone, and other people have some mobility, and you can actually get things like arthritis in the mobile parts of the coccyx, or you can end up with inflammation at the tip there just from pressure and contact.
Mm-hmm.
So yes, we try and figure out whatever contributing factor there is, we work on that. If it's muscle tension, we can do release work, dry needling, give you stretches, advice about exercise if you've been overloading certain muscles with exercise, or if you need to pick up and strengthen certain ones.
Mm-hmm. Is there a place for stretching for your patients?
Yeah, I think there is. Yeah, for sure. Actually, I think, is there a few examples in the slideshow later on?
Yep, we had. There we go. Oops, sorry.
So because your glute muscles attach on to the coccyx, if you're stretching your bum muscles, you're going to potentially get less pressure, less compression at the coccyx. So there's a few in there that are more for, I think cobbler pose is the second one there. That's
Mm-hmm.
not a direct, that's more a hip joint kind of stretch.
Mm.
In some cases, they use that almost like a pelvic floor stretch.
Mm.
Yeah.
I find it's a bit useful for the opening, and I tend to do it rather than sitting. I'll probably do that more lying down, and I find it very good for that opening feeling of the pelvic floor and the groin, because I often find if there's gripping, it's gripping around the whole lot. They're clenching, and then there's often secondaries through the the pubis, and also if there's concomitant pubic symphysis pain, unusual with just coccyx pain to have pubic symphysis as well, unless it's around pregnancy.
But if it's coming from the pelvis, yes, you can have SIJ and the pubic bone in front, definitely. And I tend to give, with the cobbler pose, I tend to give happy baby. Do you know the happy baby?
Yeah.
So
I find you've got to be a bit careful with that one. You talk about it with the guys. I didn't put that in purposefully because I think it can have some issues. But yeah, go for it.
So I can't really demonstrate it in a space.
Yeah, explain it though. Absolutely.
It's kind of you're lying on your back and you're essentially pulling your knees open and down. So you end up with your knees almost beside you.
Which is why you can see why we're sometimes a bit hesitant. So for some women who are very flexible, it can be really nice. You try and grab your feet and you split sort of the pelvis a little bit. Yeah. I tend to find standing. I'll do it standing and do a groin stretch, as in drop the body to the side.
Yeah, cool.
Or if you're in kind of that downward dog position and then you drop down, you know, when you bring your leg up right near your shoulder, sort of that one where you can open and stretch things. So I mix it around, and it really depends on your patient's experience with different exercises, what they like to do and where they're tight, you know, where we think the main driver is for their coccyx pain.
And while we're talking about stretching, we can talk about what we do for the pelvic floor part as well. So typically, if we think the pelvic floor is a contributing factor, we would give some instructions on how to get it to relax. So we would walk someone through what it feels like. And so some of these people thinking that the pelvic floor is an issue, some of them have been doing strength work, and they think strengthening the pelvic floor would be the way to go. But all that's going to do is drag the coccyx under and stop the whole coccyx pelvis unit from sort of moving normally. So sometimes you've got to release off the pelvic floor and get it to stretch. So we might walk someone through awareness of how to activate their pelvic floor. What does that feel like compared to letting it go? And focus on the let go part, focus on the relaxation, and trying to maintain that relaxation where it's appropriate. You don't need to be gripping with all of the normal tasks you would do during the day. You don't need to be gripping your pelvic floor when you get out of the chair. You only really need to deliberately grip it if you had other pelvic floor disorders, but we won't get into that at the moment. But we might use what we call an awareness dot. So we draw a dot on your hand. When you see that dot, what you're going to do is check whether you think you're holding tension in your pelvic floor. So bring your awareness to your pelvic floor and your tummy. If you need to, do a brief lift and then let go and let your tummy go heavy and let your pelvic floor go heavy. It takes a bit of awareness and it takes a bit of knowledge about where your pelvic floor actually is and what it feels like. And not everybody feels a drop. It depends on how much tone they've got. So some people get a good relax and some people don't feel like they can feel much. But obviously if they're seeing us and we're checking their pelvic floor, we can walk them through whether they're doing that effectively. We can actually assess if they're doing that let go effectively.
How much of if you think to the coccyx pain patients you've seen, and to our listeners, Mel sees a lot of coccyx pain patients and the very chronic ones, so she'll have people travel a long way to see her. How many, what percentage of those have primary pelvic floor driver or dysfunction? Or when it's that chronic, does it become they've got everything? They've got nerve, joint, muscle.
It's a
What
good
do you
question.
think?
Yeah, it's a good question. Primary, with it being the only reason why they're getting it, I would say not often. So,
What percentage, if you were to grade percentage-wise, if
yeah.
we say, okay, let's talk about core gripping, floor gripping, neural driver, so pain sensitization, bowel issues, what percent do you think the pelvic floor plays, be it slightly external and internal, on coccyx pain?
A percentage of the pelvic floor being an influence at all, probably at least half.
I'd agree with that.
Yeah.
I'd agree, because even if it's not primary, it becomes secondary because
Exactly.
of pain they grip. And so I think the importance of having a pelvic floor assessment is huge, and both an internal and external one,
And
in
it's
properly managing
a
this coccyx
really
pain.
commonly missed factor as well. So often they've had everything externally done. They've seen lots of other providers, and they've seen lots of other types of allied health, and they can have had everything done externally that's possible, and it's just the missing factor sometimes. And sometimes there's other dysfunctions in the pelvic floor related to a tight pelvic floor they didn't even know were related to a coccyx pain.
Yep.
So they can say things to the effect of, I have trouble emptying my bowel, or the poos come out really skinny, or something like that. It just sort of indicates to us that they're not fully relaxing that part of the muscle system. If they've got a generalized tightness through the pelvic floor, they could even start reporting things like pain with intimacy. They might have issues with voiding their bladder, having to push when they wee, that sort of stuff. There's a lot of other factors they may not have even realized are related.
And how much, once it's kind of all those things are layered in, can they ever be primary, those secondary, what we would consider secondary things? Do you sometimes find they're the primary cause of the coccyx pain because they might have had bladder or bowel dysfunction for a long time?
Exactly. You know what? I've seen a few that have been, let's say, an overactive bladder as a child. And so having an overactive bladder as a child means that they develop this compensatory gripping of their pelvic floor. And then later in life, that adds up to an increased risk of coccyx pain, or it's helping drive their coccyx pain. I've seen instances with a bout of diarrhea, and they were gripping because they were holding in their diarrhea, and that led to the problem. In the other way, you can have constipation give you coccyx pain as well, because the pressure in the rectum can feel like a coccyx pain.
Do you, again, in your experience, would you rate I'm throwing them out there to you, Mel, because we haven't planned any of these. What percent of your coccyx pain patients do you think it's coming from sacral, as in they're sitting on the sacrum and it's driving pain to the coccyx?
Yeah, at least half. Yeah, at least. I'd probably say there's a compression postural factor in probably 60 or 70% of them.
So let's jump to that, because I know we've got an image on sitting, and let's talk sort of tips and tricks for people if they're suffering with coccyx pain. What's the key advice, again, that you think is a point of difference? You know, they'll see other practitioners, but they don't talk about this specific stuff. So let's jump to the sitting one. Apologies, the screen appears to be a bit slow to flick through at the moment.
So I think you've got a few examples of what you'd call poor sitting posture. Have a look at the first. Actually, you've got a bit of a mix here. Go to the bottom row in the front. So she's got the same chair the whole way through this bottom row, but she's got an example of slumping backwards, right? Which is meaning that she's effectively weight bearing on her sacrum, which is that triangular shaped bone, and weight bearing on her coccyx. And the coccyx isn't really designed to be a weight bearing structure. You're supposed to be weight bearing on your thighs and on your sitting bones. So those little joints are not designed to cop that much pressure, especially for the length of time that we end up sitting on our bum. And so typically what a person might say is either it hurts when I sit and progressively gets worse, or it hurts when I stand up. Because sometimes it's not the sitting and the compression that hurts so much, it's when they stand up and they all of a sudden release the pressure off and they go, that kills me, and they have to walk around. And eventually it gets better, and then they do it all over again and sit on it again. So that's the first one's no good because she's slumping back on it. And the second one's no good because she's rolling back. So instead of her upper body being shifted backwards, she's tilting her whole pelvis backwards, and so she's still sitting on it, right? What I see a lot of people do is they get off their coccyx with something like a cushion, or they get those donut cushions or something, but they're still slumping, right? So if you're sitting badly on a cushion, it's still kind of perpetuating this stiffness, this positioning that your pelvis goes into habitually, and you're never quite getting your proper flexibility back in the position that your lower back and your pelvis should be achieving, and your hip joints should be achieving. So if you're almost sort of cheating and you're using a cushion, but you're not getting a proper sitting position, you're not quite getting the whole benefit, if you like, and you're still keeping all of those muscles under your bum really shortened. Because instead of being, have a look at the second row down, the last one, how she's sitting up so tall. Yeah, that one. See how she's got that nice, that arch through her lower back? And so she's got this elongation of her hamstrings and her bum. And she's probably you got to have reasonable flexibility in those muscles to achieve that position. So if you're only ever tucking under and using a cushion, you're never quite getting that range back. And it can have a lot of other consequences for your standing posture and how your glutes function and how the rest of your pelvis moves and your lower back moves and everything. So what we're aiming for essentially is for you to sit and weight bear on your actual thighs, on your sitting bones. And yes, you can still use a cushion. You can still use a cushion because it can still spread and distribute the force a little bit better. The other bit that you might want to note is how deep the chair is. So depending on your height, if you've got a deep chair where your knees are higher than your hips, you have no choice. You're going to tip back a bit.
So that top image, I think, describes it quite well. It's really hard. Yeah.
So that's still not ideal, because even if he tries to sit tall, he's tall enough that his knees are still higher than his hips. So he's going to need to get a cushion underneath his bum and lift him up a little bit to try and even out the pressure, because he has no choice. He's going to roll his pelvis back a bit just because he's so tall. And this is a problem we see a lot with the sofa, because everybody's couch is a bucket seat. So you end up rolling your butt back and sitting deep in the seat, and everybody ends up in that position. So we see a lot of things like postnatal coccyx pain from sitting parked on the couch for hours at a time, breastfeeding and things in that deep position, or sitting breastfeeding in bed because they're chocked up with hardly any. They've got cushions behind them, but they've still got their legs out long and they're still tilting. Can you see my hands?
Yep.
And they're still tilting back like that because they're sitting upright in bed. So really we're aiming for education about posture. And one thing we see people do is they think they're sitting tall, but what they do to sit tall is different for different people. What they might actually be doing is arching their upper back, and that's them sitting tall. And so they say, I've got fine posture. Everyone's told me about my posture. I've tried to fix that. But then when you get the actual pelvis and you shove their pelvis, they go, is that what you mean? And I've seen a couple of cases where someone's had, let's say, a brand new back injury, like a lower back, a true lower back injury. And because of that lower back injury, they can't sit tall in their lower back. They lose that nice arch because it hurts to do that while they're recovering. And so they end up slumping, and the whole thing sets off a coccyx pain. So then those people have got to regain their flexibility in their lower back. Yeah.
And so what do you recommend in the interim? So for those ones who've got tight hamstrings, tight sacroiliac joints where the sacrum's not flexing, and or back issues, how do they compensate?
Try and get your hips above your knees just slightly. It doesn't have to be massive, but try and have your hips above your knees slightly. Use cushions, use your seating while your muscles are catching up and trying to stretch, and we're trying to fix all that sort of stuff up. A cushion behind you gently, but it doesn't have to be up high. Where you want the cushion is sort of just at the lower. Can you point to where we would typically put our cushions? It's sort of right at the lip of the bum, not in your lumbar spine, but kind of put the rolled up towel or the cushion.
Oh, sorry, here. Yeah, sorry, you mean
at the back of the pelvis. You want it at the back of the pelvis, because a lot of people use those the half cylinders and things, but they put them too high. Yeah.
Sorry, are we talking the cushion under the bum, the wedge cushion, or the one at the low back?
You're going to put one behind you.
Yeah, okay.
Put it a little bit lower than your actual lumbar. You can put it in your lumbar, but often people put it too high. If you put it
Yep.
too high, it just sort of pushes you off the chair. And
Yep. Yeah, it's definitely got to kind of be low here. I'm
yep.
a massive one, as you know, Mel, for cushions. So I would start, even if a person's posture we think is good, just to help them. I'm so big on the wedge style cushions. No
Yep.
donuts, please, anyone. The wedge style cushions, or if you don't want to get those, just your cushions from your couch. Those dense ones that are narrow are great in the car. Just gets the bum higher than the knees. It makes a massive difference.
Yep.
Because the biggest things Mel and I see is that you're just rolling back on your coccyx. Do you want to go through the speed hump? Just because I think it's a brilliant little thing to do for people to double check.
Yeah, it's just an awareness technique. So what you do essentially is find your sitting bones. So you tuck your hands under where your sitting bones are the top of your hamstring. Okay. So we're underneath the bum, kind of at the top of the hamstring. And you should feel a bony bump. Okay. And what you're trying to do is roll back off the back of your hands. We're imagining your hands are the speed bump, or that your sitting bones are the speed hump, okay? And you want to try and feel rocking back off the back of the speed hump, and then rocking forwards off the front of it, and then come back to perch right on top, okay? Trying to sit bolt upright over the front of your speed hump often is uncomfortable because you're just jamming up your lower back and you're making your muscles work too hard. Sitting rolled off the back is you weight bearing on your sacrum and your coccyx. So you try and perch on top, which would be a nice neutral position. And what a lot of people have to do is check in regularly with their speed hump and figure out where they are and whether they're sitting neutrally on top.
Perfect. And checking regularly with different surfaces. Hard surface, you start on a hard surface because it's so easy to feel with the hard underneath you, under your bum. And then the softer surfaces is a bit harder to feel, but because you've had a bit of practice on the easier to feel surfaces, you'll get the idea. And it is invaluable because you kind of go, oh, jeepers, I am rolling back. Or when I tire at work, my default is just a boof, just to sit back on that sacrum. So it's just spot checking often and have reminders often. And that, I think, is our key point of difference when we manage. If you can get, whilst we're working with all the other stuff, if we can get you off that sacrum so you're not constantly irritating it and annoying the bone, it'll heal. But remember, it takes a good 6 months if you've had chronic inflammation around a bone for it to calm down. Because you've got bony, at a pathological level, bony inflammation, and that takes a bit longer. So donut, why not a donut, Mel?
Donuts, I think, were designed more for hemorrhoids originally, but they're not great necessarily. They can form sort of a pool of pressure in the middle. What you're essentially doing is you're weight bearing on the outside of the ring, but then you're forming this potential for pooling of blood flow in the center of the ring. And for some people, that's not great for pelvic floor management, for hemorrhoid management, if that's what they've got. We don't want to pull more pressure there. Also, the donut would mean that you may actually have your coccyx resting on the back of the donut, which is just adding pressure. Some of the nicer ones are a wedge with a U-shaped cutout at the back.
Yeah,
so
I've got a picture.
So they're a wedge which brings you into the position that we were talking about with your hips higher than your knees, but they're also, they have a U-shaped cutout, which is probably a little bit better.
Yeah.
So you don't have direct compression.
Perfect. Okay, so we talk about pillows, wedges. So that's the detailed stuff with sitting. We've talked about other conditions that may go to coccyx pain. Is there anything else? Oh, I suppose the other real one that I always find surprising, and I think you do too, Mel, we've talked about this in terms of so many patients will come to us and they'll say, I've been to my service providers and they said there's nothing we can do. Where do you think the healthscape is at presently with the management of coccyx pain?
You know what, I think there's probably not a great education for a lot of health providers about how coccyx pain works and what physios can do for it. That there are treatment options. In terms of all the body parts that are researched, coccyx is one of the ones that's researched less. So I think there's less information out there in total for doctors and other health professionals to know what the problems actually are, how they're caused, what you can do about them. I think some of them get sent off to specialists and they skip the physio step, not having enough information about what we do.
It'd be great, wouldn't it, if we could kind of get that step involved much more. Of the patients that you've seen, how many have you achieved together full resolution? What
I've got a few
percentage?
that are still. If I let's discount the ones we're still working on, the working in progress.
Yep.
I've got to say the ones that haven't had full resolution have been very complicated. So it's not just a coccyx thing we're dealing with. It's a multifactorial pudendal neuralgia kind of chronic, really heavy issues. And typically they have lots of different people involved. They've done nerve blocks. They've done lots of other stuff. They've had lots of other interventions. And if it's not multifactorial and complex like that, I'd have to say all of them have done really well.
Yep. I'd say the same. Over the last 10 years, there's only 2 that I can remember that we haven't had incredibly good results with. One of those, the coccyx, was completely angled the opposite direction. And another one actually went and did shockwave therapy, which is kind of outside the standard research at the moment, but she got good results. Let's jump to, you did talk about these neurogenic ones, and I think they're the more complex ones. So how does a neurogenic, or what we think of as a neurogenic coccyx pain, differ to non-neurogenic in terms of its presentation?
Yeah, so if you had a typical mechanical coccyx pain, it's usually fairly simple. I sit, it hurts, or when I get up, it hurts, and when I walk around, it feels better. When you push it, it hurts. When you don't push it, it doesn't hurt. So it's a pretty mechanical kind of presentation. You don't get resting pain being if you're lying down, not touching it, it doesn't hurt. Whereas when you've got grumpy nerves, it sort of becomes a little bit more expanded. The level of pain is often higher. There can be the quality of the pain can change. So it can go from an ache or a sharper pain to more like a burning. The quality of it is more neural in nature. It's nastier, if you like. You can get other nerve type symptoms. So you can get tingling and numbness and the other part is that there's often a prolonged pain after anything that hurts it. So instead of saying, I get up, I walk around, I'm okay in 2 minutes, they go, it hurts for half an hour afterwards. Or you palpate and they're sore for the whole day after you've just touched them because everything's just so hypersensitive.
And how does your management differ? What gets involved with these patients?
Right, well, if they are neurogenic, there's a few extra things you can try. So from a physio point of view, you'd still be going through your muscle relaxation, that sort of thing. You'd still be doing your down training, your posture, your cushions and everything to get off it because you don't want that constant neural drive by pushing on it all the time and you're just perpetuating that neural sensitivity. You'd probably back off on any direct pressure stuff you would do because you're driving the pain cycle. You could consider a TENS machine. We'd use a TENS machine a little bit it's like a neural modulation, or you're trying to change the behavior of the way the nerves are talking by using the electrodes. I don't know if everybody's familiar with that. It's similar to what you use in an obstetric TENS machine. So it's just electrodes that form a buzzing sensation. And what's happening is your nervous system is sort of sensing that buzzing rather than sensing the pain, if you like, very simply put. Right? Yeah. And over time, it can sort of recalibrate the nervous system a little bit. The other thing is, if it's bad enough and if it's bothersome enough, we can get medical intervention and you can do things like nerve-based pain medication or central nervous system-based pain medication. And that, in conjunction with the physio for the really nasty ones, can have a better effect.
Yep, agreed. Awesome. What, in terms of males versus females for coccyx pain, how do they differ? Do they differ in their treatment or not?
I suppose the difference I'd find is the females, the reason why it happened. The males are more often something like a trauma or that sitting position. They've been sitting on it a lot, or they've had a fall, or they've come off a bike, or they've had some sort of external pressure. The other reason males get it is from the pelvic floor gripping. Yep. But I'd say the female population, the difference might be we see them having a pelvic referred pain a little bit more often, because males not having the hormonal fluctuations we do with a menstrual cycle and with pregnancy, they've got a pretty steady hormonal profile unless they're on some sort of hormonal management. And that means that their pelvic joints are less temperamental, if you like. So females having a hormonal cycle and pregnancy and things, they can have more mobility in their pelvis, which means we see more often it's pelvic joints referring to coccyx, which I see less in guys, I think. With the exception of, I've seen a couple of guys that have a really, really stiff, really super stiff pelvis, and that's been an issue.
And we're in our gender diverse populations. Does it differ?
I suppose if we talk about there are members of the gender diverse population that have had surgery, so I think it would depend on where they are along their hormonal / surgical journey. If they're on hormonal blockers, so guys would have testosterone blockers and estrogen supplements, and sometimes that changes things for them, because estrogen changes how the ligaments behave, and it changes how the muscles behave as well, actually. For females, they would be on estrogen blockers. That might change their hormonal profile a bit. And then if they've had a surgery or they've had some type of procedure, that will change what's happened with their pelvic floor and how their pelvic floor is behaving. And I think there's not a heap of research about how the pelvic floor changes after these surgeries yet.
Yeah, we haven't got enough,
No.
in terms of the research side.
But
so sorry, go on.
I was just going to say, it certainly is a consideration. So depending on what they've had done, that can change the intrinsic behavior of the pelvic floor, if you like.
So it's still gender diverse, those with a penis, those with a vagina. Really, management is just all what we see, we treat.
Pretty much.
So treat the parts that contribute to the coccyx pain, and we generally get good results.
Like female set of management and male set of management. It is just really individual.
Yeah, okay, and we treat as is. All right, fantastic, Mel. Is there anything that you want to do or say to wrap up in terms of summary for coccyx pain management and for anyone listening out there?
I think we've covered it really well. I think if people can take away a couple of really simple things to think about, your posture, your cushions, your pelvic floor, knowing a little bit more about how it can be fairly simple to treat in a lot of cases, and you don't need a hell of a lot of input in some cases, and that there is a lot of help if you come and get some assessment done.
Yep. And if I can just say to you, I know Mel won't say this herself, Mel is absolutely brilliant in this space. I keep pushing her to do an Australian course. I believe she's one of the best practitioners in Australia. So if you know of someone who is suffering with coccyx pain, please don't hesitate to recommend Mel. She's predominantly out at Taylor's Lakes. And yeah, I recommend her all the time, and I'm a tough taskmaster, and I know Mel's fantastic. So thank you for listening to our coccyx session. Thanks, Mel, for your expertise in the management of this, and we hope that this has been relevant and of interest to some of you listening out there. Our next week's session, we're going to be having Cara Richmond come on to talk about bowel. So everything that you wanted to know about your poos, what is normal, what's abnormal, and what can you do about it. Again, like with coccyx pain, there's a lot of people out there suffering and not knowing that there's simple fixes. That is the biggest thing for both Mel and I that we find frustrating with coccyx pain, is so much of this is an easy fix, and most of our patients find the same, definitely in coccyx. The third week, so next week is bowel, then the week after that I think is going to be a great one for a lot of you. We're going to be covering kids' pelvic health. So that's going to be daytime wetting, nighttime wetting, overflow, and if we get time, a bit on toilet training, the do's and don'ts. So don't miss our next couple of sessions, and please don't hesitate to email us if you want us to cover anything more over COVID crazy time. Take care of you and your family, and we look forward to seeing you next week. Thanks, Mel.
Thanks, Alex.